Tabitha Wandera, and I'm a student at the University of Arkansas Ellen Oman School of Nursing. And my instructor is Mrs. Kadit Roop. And today is November the 30th, 2023. And I'm presenting to you. And before I begin my presentation, I would like to introduce to you people who have been very special in this project. And one of them is my preceptor, Dr. Jen Stewart, who is the director for ICU and medical surgical unit. And the other one is
Kim
Malinga, who has also been helpful in providing me with the information, internal data I got from her. She's the Quality Improvement Director and Risk Management. And so we were asked to come over and look for topics which were necessary to improve in our workplaces. And therefore, my preceptor and I sat together and we discussed about what was going to be good for us to do. And then we found out that she told me to come and research on heart failure readmissions. And so that is what I did, and I got some information to share with you. So, reducing heart failure, 30-day readmissions and improvement project in the transition care clinic at North Texas Medical Center. And so I'm going to go to the next slide, and the next slide is on the data that I received. As you can see, this is about the heart failure, COPD, and pneumonia. And as you can look, when you look at this, you see that when you compare the three of them, you can see how the articles, there was a lot of readmission in February, which was like 40%, and then in March came down, and then it went up again and came down. September was really bad for heart failure patients, readmission. And so compared to every one other diseases, like we have seen chronic congestive, chronic obstructive pulmonary disease. As you look, that one it can be compared. These two cannot compare with heart failure. This is just to show you the problem that there is in this hospital, and so we are trying to work on that one. So this next one, it talks about this is just the data that I used to generate the graph, which I got from the Quality Improvement Director. Okay, so here we have, okay, let me come down here. Okay, so this is what was found from literature, and as you can see, heart failure is still persistent. It's a major problem, not only to adult patients, but also to hospitals. Literature shows that 25% of heart failure patients are readmitted within 30 days of discharge. In fact, 50% within 60 days, whereas 50% of patients admitted with heart failure die of the disease within five years. So heart failure readmission, if prevented, can save the hospital some money and improve patient lives. So heart failure readmission reduction is among the national target health issues to be addressed according to the hospital readmission reduction program. That is why the heart failure 30-day readmission reduction project will be a beneficial to the North Texas Medical Center. Okay, so, and as you can see, like, you see it affects 36%, 38% of, I'm trying to remember this one here. Okay, 38%, okay, 38% million people worldwide and 6.2 million people in America. So, and the problem, you see mortality is high with these readmissions. We see morbidity and also readmissions. So I already mentioned about the 25% heart failure readmission. Okay, so the next slide is heart Yes. Okay, so transition care clinic. Let's see what we are seeing here. Okay, so data from literature. Okay, so from literature, transitional care clinic intervention decreases heart failure, and that has been proven in the literature, evidence-based literature. So it has worked before for others, so it should work for us also. So, and one of them was there's a systemic review study on the transitional care process, which was carried out, indicated that interventions such as nurses, pharmacists, and healthcare providers played a major role in the reduction of heart failure, 30-day readmission rates, significant improvements of quality of life, 14-day follow-up appointments, compliance, 18-day readmission rates, and mortality rates. On the other hand, a study on paramedic community visits showed to decrease heart failure 120 days readmission from the intervention group compared to the control group, which was like the difference was big because it was 34.6% to 64% respectively. These are evidence-based interventions that have worked to decrease heart failure readmissions, and it is, if implemented in this facility, it may also reduce the frequency. Okay, so next. Okay, so I think there was something more here which I need to.
You can use the arrow keys too to get to the
Which
right
one?
slide. Your up and down arrow keys on the keyboard.
Oh, this one here?
Mhm.
Oh, maybe that will help me.
It
Okay.
might help you with your slides anyways.
Yeah. Okay. So that's the one I lost. Yes, that's the one I did. So I'll bring the next one. Okay, so we are talking about the payment values of care, patient treatment compared to all other hospitals nationally, mortality and complication rate payments, and we had HF 30-day risk standardized payments. Okay, hospitals payments are based on payment value of care given to patients at the hospital compared to other hospitals nationwide. They are classified, there is better, low, better, and average. And so better payments are preferable than average. Our goal is to achieve better category because payments received from Centers of Medical and Medicare and Medicaid Services, CMS, for heart failure and pneumonia was at average. So we received the average payment for that one, for the heart failure. So this facility supports better care for patients, better health for the community, and low cost also. And so our goal is to go to better. We got average, but now we need to move to better so that we will be able to have some benefits over there. Okay, so let's see, this one is, this one we are, population setting and stuff. Okay, so this one, the population is adult diagnosed with heart failure and transition care clinic within North Texas Medical Center. And then there's staffing, there's project team, project leader, we need one. Nurses, we need two. Healthcare providers, we need two who can be nurse practitioners also. We need pharmacists, one, and also assistive personnel, we need two, and ICU. So in the professional team, coordination plays a major role in patient-centered care because each team member comes with their expertise from their disciplines. A systemic review on 17 studies was done, and it was noted that care coordinated process is a is an elaborate move that puts the patients first and allows them to solve, them to share their health needs with the interprofessional team for a better outcome. Interventions included patient education, patient compliance, telemonitoring, referrals, community services, post-discharge follow-ups by telephone, home visits, and ambulatory clinics. The proposed projects, the team members to make the project successful will include the project leader who will work with the preceptor, the ICU unit, and medical surgical director to make sure that the project runs smoothly at North Texas Medical Center. 2 nurses to coordinate and run the transitional care clinic operations will be required. Nurses will be responsible for calling the patients and carrying out patient assessments and treatment in the clinic as prescribed by the healthcare providers. 2 healthcare providers will and then the 2, one pharmacist and nurses will work with the patients to be sure they understand the discharge information and the follow-up requirements. Nurses will read discharge information to patients and explain it during discharge. And that is, the reason for that is because sometimes we just give the patients information and let them go, but they don't really understand what it is. So they just go and dump it there and they don't. But when you talk to someone, they are able to understand and ask questions, and that will be an opportunity to tell them what to do. The 2 assistive personnel, these are like the direct care support, and normally within the clinic now, they will be receiving the people when they come, and then they kind of take their personal information and enter there so that when the nurse comes to take them in, then everything is there, and like insurance and everything that they may need. So that is about that. And other team members such as dietitians, physical, occupational, respiratory therapists will be sought based on the patient health needs and as per health provider judgment. 2 healthcare providers will be responsible for seeing the patients and referring them as necessary. And you see, that is because, like you need to, because if one is sick, the other one can be there taking care of the clinic so that it runs smoothly and there is no delays. So I'm trying to see where I am. Is the 8? Okay, thank you. So let me come down here and see what I'm doing. Okay, problem background. So we are talking about heart failure that day readmissions. It's 19.5% today here in this facility. Heart failure that day mortality rate is at 17 and 20%. There is no difference. You see, when these people did data displayed in this slide is from Springfield News Leader, and that is where I got that from. And so we're talking about the payments is based on mortality, stroke, complication rates. What is happening here? I don't know where to. I didn't do anything. So what do I do?
Just quit. Just quit.
Quit.
Yeah.
Okay. Sorry about that. Yeah. So okay. So we are talking about. I'm talking about the payments is based on mortality over complications rate that are classified in 3 categories. Was apparent later. I think we talked about that. Therefore, risk standardized payment as it is related to heart failure. That the episode of care was an aberrant also received in this facility. So mortality payment was 19,642. So our goal is to get to better, a higher category, which will benefit the facility as well. Okay, so let's go to 9. it, I can use this. So, 9. Okay, now. Heart failure. Okay, heart failure program interventions improve lives of patients diagnosed with heart failure. For example, a systemic review and meta-analysis, the study was carried out among 671 participants from 47 skilled nursing facilities to determine if heart failure disease management in skilled nursing facility improved the outcome of patients with heart failure. Results indicated that there was no significant difference in 30 and 60-day post-skilled nursing facility admissions. However, mortality rate in heart failure disease management program was 5.2% compared to usual care at 11.8%, which shows heart failure disease management reduced the hospitalization among adults in skilled nursing facilities. And then another quantitative research study that examines the impact of community paramedic interventions on patients diagnosed with acute myocardial infarction, chronic obstructive disease, and heart failure, and 30-day readmission, 120 days and 210 days post-discharge indicated that participants in the interventions group were less likely to be readmitted at 120 days and 210 days post-discharge. Also, intervention program participants had visited the clinic once in the first 30 days, then in 120 days and 210 days. Those paramedics visited the patients twice a week in their communities for 30 days, which helped reduce readmissions. Therefore, community intervention can help reduce the visiting. You know, we are talking about visitation. When you visit them, you go check their blood pressure, you find they have issues, you teach them, and then that will help them and prevent them from coming because they already know what they can do for themselves to be able to take care of themselves. So that is how that was helped. That helped them reduce that. Then we also saw that there's literature, it is indicating that when there is pharmacists involved in a professional heart failure management to determine the effects as it relates to heart failure hospitalization, heart failure, mortality, medication compliance, knowledge, health care costs, self-care, and composite endpoint to improve clinical outcome. The results indicated that hospitalization was reduced, but not mortality. This is all mortality, it's all reduction. So in addition, there was a significant reduction of all cause hospitalization, but no difference in all-cause mortality. This study underscores the importance of including pharmacists in the professional team in heart failure management to better health outcome. Medication compliance and lack of understanding of their use may be associated with frequent hospitalization readmissions, which a pharmacist may also play a great role in educating the clients about medication and their use. Okay, so this is evidence-based. This all information is from this writers here, evidence appraisal. As you can see, that is a summary of all the literature that we used to come up with that data. Okay, so stakeholders. So here we are talking about the people who are interested in this program, and we have in the professional team, and those are the ones who are going to be part of the project. And me, I'm interested because I want to make sure this facility is getting more money and the patients are feeling better. Pharmacists, we have seen what they can do, the role of them, medication reconciliation, education, and teach them about the advanced effects of medication. And then patients and family, they are the core people, because without them there is no job. You know, we work for them, and that's why they are here, and they are key people in this project. So nurses, you know our work. We are all nurses as we are here. We are training to be nurses. And as you can see, we do a lot because we are the ones who are really with the patient daily. We know how they sleep, while they wake up, everything, and we can assess and make judgment based on that. So we are important too in this area. So healthcare providers, of course, they have authority to give prescriptions and to see patients in ways that we cannot. And so they have their specialty in that, and they are important people to be here. Assistive personnel, they are unique too, because guess what? They are the ones who run together. Oh, this person, he doesn't look good. Not like yesterday, he has changed, and then gives you an opportunity to go and assess. So they are very important, and they directly take care of the people, the patients. Emergency care department, why did I put that? Because that is the entry point. When the people are coming to the hospital, they come to ER first. When they come there, then they know everything, the diagnosing is done there, everything is done, then they are admitted to the hospital, where then we follow them up and then follow them and find out and introduce them to our program. And now we kind of help them through the process when they are coming. By the time they are discharged, they already know what our clinic is all about, and they will come over here and we give them the information to come, and we follow them up so that they can be compliant with the appointments to be seen. The chief nursing officer, of course, you know, she's in charge of the hospital management, and she's after compliance, and wants the patients to be well. So she's also a very unique person to be here. The other one is the chief executive officer. Of course, without her, there's no money. So she knows how we can get the money to run the clinic. So if we need finances, we go to her, and then we kind of let her know. She knows what can come to us and what cannot. So she's a very unique person here. Okay, quality improvement, Kim is here with us, and she is the best. I mean, she's qualified for the job, and she follows everything. Even in meetings, when I hear people talk, and then she will say, I didn't know about that, and then like everyone is running to go, and she wants to make sure quality care is given in this facility. So that's a good thing. Thank you for your job. Also, Chief Finance Officer, I thought I talked about Chief Finance Officer, but I guess it's the executive. That's the one I thought I was talking about the finance, but executive, that is now the overall boss for the place. And he is a good man, and he takes care of this place. His desire is to see that the hospital makes profit, and also the patients receive the care they come here for. And that is why we have to make sure we support him by doing our job, so that also he can improve. That also promotes the hospital itself. Okay, so he's a very important person for this place. And then our ICU director, who is, I'm proud of her. She has really been with me in this program. We have been together, and I have learned a lot from her. And so she is going to be part of us, because I am really directly related to her, because we work together. We are a team, and we want to make sure the clinic starts. Okay? Thank you. Okay, so the next one we are going to, let's see, I think I've done all this, talked about the roles. These are just the roles of every person. Talked about the pharmacy, social worker. Social worker, of course, you know their job. They are trained to be able to get resources for the patients, and so they are very important, because sometimes heart failure patients, they need a lot, and sometimes they need some equipment which they have to go use at home. So she will be good for that. We need a case management. Case management is really vital in this program, because she is the one when the ER sends them to there. She will take a package with them, talk to them about the program, explain everything, teach them what they need to know, and then make sure they come to the clinic, follow them up. So, okay, house supervisor, why is she here? She's here because she's in charge of overseeing facility operations and staffing. And therefore, whenever she's there, the house supervisor makes sure that the facility is covered and is scheduled, and employees come to work. So, if there people call in, then she's able to get people, and she's vital because she can kind of get us someone to work in the clinic, to know who is it who can come to cover them. So So that is why she's important also. So the other one is the project leader. The project leader will work with the stakeholders and in a professional team to ensure that the project succeeds. She will work to encourage open communication and mutual understanding, respect and share responsibility and decision making to promote quality of patient care and improve 30-day readmissions. Okay, so that is that. I think that is the last one. So when we use this, I think this one helped me. Okay, let's see. I'm trying to go up to the 11th one. Okay, so we are on 11. Okay, let's come here and see what's on 11. Okay, that is my aim statement. And it's implement 70-day follow-up clinic visits within 70 days of discharge to decrease heart failure, 30-day readmissions by 5% within 6 months among adults diagnosed with heart failure at North Texas Medical Center. Why did I choose 5%? I chose 5% because an improvement doesn't just happen so fast. It takes time. And so you don't want to go to a higher number that you can't achieve. So I thought 5% can be achieved within 6 months. And that's why I took that 6 months. Okay, so next. Okay, so this one is a professional team project team leaders, and these are, okay, I'm one of them. And my work is to, let's see, I need to say it so that you get it well, because we already seeing the aim statement, so we need to make sure we are doing well here. So my work is to collect data and develop a quality improvement project to decrease heart failure 30% readmission at North Texas Medical Center. So chief nursing officer, of course, I said she oversees, she's the overall nursing care at the facility and will be beneficial to the project for its success. Healthcare providers, primary care providers are privileged to write prescription orders for patients, for patient care and their needs. They will be involved in seeing patients and ordering referrals to the community. Okay, so ICU and medical surgical director, who is my preceptor. So we work with me, who is the team leader, to guide on project requirement fulfillment. Quality improvement director, she's also part of the team, and will assist the project leader with the data resources that may be required for project purposes. The nurses are vital health, as I said earlier. They are team members that will explore identified health problems. Assistive personnel, they assist patients with the activities of their living, a vital component of patient care. Nutrition or dietitians assist the patients with nutritional health needs. Okay, so pharmacists we have seen in charge of dispensing, preparation and management of medication for patient safety. So nurse case manager, RNs, they coordinate patients with resources such as in a professional team for better lives. So like, you know what they do, they will just case management, case by case, and then bring all these people who come together, discuss about that patient. We do that here all the time. And so she's a very important person for that, to do that. So I think the patient, of course, we can't leave the patients because they are the key people who are supposed to be helping us, getting us paid. Okay.
God bless you. God bless you.
Okay, so we are going to 13. Okay, synthesis and dissemination. Okay, so synthesis and dissemination of projects. Data will be gathered and compiled. Results with the preceptor and course instructor for guidance. Consult with the preceptor and course instructor for guidance. Consult the quality and improvement director for internal data. Yes, and communicate via emails and face-to-face. Data collection of heart failure readmissions reduction will be researched from the University of Arkansas Library, and by narrowing down to cumulative indexes to nursing and allied health literature, complete database. So it is where we go and get all the information, and they have really written a lot of work. So in a lot of topics, so whatever we want, it's a better place to be for nurses to get information, whatever they need. So that's what I will be doing, using that one to do research. Okay, this is just the same thing continued, and we are saying, okay, so I'll sell the project idea to the chief nursing officer, present project to the quality improvement director and preceptor. That's what I'm doing now. And educate the staff on heart failure that day. We had mentioned that will be done during the implementation. Pilot test will be done, and then revise the intervention and re-educate per need. So now the chief nursing officer has the power to approve or disapprove the operation of the project in the facility. Therefore, she will be informed about its plan. She is one of the stakeholders that has great interest to see heart failure that day readmission decrease. After everything pertaining to the project proposal planning is completed, a classroom setting project presentation will first be given to the ICU, medical surgical director, and the quality improvement director. The rest of the stakeholder members of staff will be educated weekly on heart failure, that day readmission reduction management. Until the desired target is met, any new staff recruits to the team will be trained on their first day of reporting on duty. The project duration is intended to be 6 months long, from March 2024 to September 2024. 5 patients diagnosed with heart failure will be randomly recruited during admissions and will be offered opportunity to participate in the project upon their discharge. So we are saying that whoever accepts the offer will be given a consent form to sign, but will be informed that they have the autonomy to pull out of the project if they change their minds once they agree to be part of the program. They will be given information concerning the program and given an opportunity to ask questions, details pertaining to the clinic, and visits will be provided. And that's the third one. So we go to 15. So 15 is talking about the interventions. Okay, the interventions that seem to work while clients are given follow-ups information at admission and discharge. Nurse reads and explains HF heart failure comments to patients. Patients are called within 7 days after discharge for follow-up and appointments, and patient and provider in-person interaction to address health needs. And the people who did this study, they kind of saw that you see that kind of relationship is kind of carried with the patients interacting with the healthcare providers, kind of brought good relationship and good transition from the clinic to the community. So, and that continued for a long time, which really was and that relationship caused the patients to be willing to kind of continue doing what they were doing, and none of them went back to the hospital. So that's a good thing in the professional team-patient collaboration. Of course, we talked about the case management and collaboration. So she will be doing that, and all of us coming together to discuss about patient care and making sure they are okay. So interventions continued, home visits, referrals. We talked about that, discharge counseling. This will be done during discharge also. And nurse provider communication, as ISB, of course, you know this is introduction, situation, background, assessment, and recommendation. Nurses do that, and that is a tool that is there, very good one to it avoids a lot of errors and makes it easy to communicate with the doctor so they understand what, or healthcare providers, they understand what is really the problem with the patient and how they can be helped. So there's everything to do with that and the recommendations. So a tool that is effective and precise in communication. The provider will then refer clients transition to their communities, such as home health services, primary care providers, PT, OT services, and different communities based on their need. Okay, so here we are talking about outcome measures. So how do we measure these things? So to make sure that they have worked. So what I'm saying is that to decrease heart failure, that day and admission, the following measures will be completed. Number one, outcome measure. Decrease heart failure, 30-day admission by 5% within 6 months, and to determine the change, increase or decrease, is to be certified by dividing the total number of heart failure patients readmitted within 30 days divided by the total number of patients admitted within with heart failure in those 30 days. So the cycle will be repeated monthly. Data related to the program will be saved in computers located at the Transitional Care Clinic at North Texas Medical Center. The project leader will assemble and compile data monthly. Data related to the program will be saved. I'm not repeating myself here. The project leader will assemble and compile data from the parent patient charts. Once data is compiled and analyzed, it will be shared with the quality improvement director and the ICU medical director. So that is how that outcome will be measured. And now we come to the other one, which is process measure. At least 90% of team members will be receiving training on heart failure, 30-day readmission prevention strategies before the implementation of the program. The effectiveness of training will be calculated by dividing the total number of project team members trained divided by total number of the project members. Training will be weekly until the desired target is met. Also, the first day of every week, training of new staff members on the project shall commence. To keep track of staff training, the team leader shall maintain a file log on all team training activities and their attendees. This information will be relayed to ICU director and medical surgical director, who is my preceptor. The last one is another process measure, which I say at least 90% of project team members will follow up with heart failure patient within 70 days of discharge at the clinic during implementation of the project. This is calculated by dividing the total number of patients seen at the clinic divided by the total number of heart failure patients admissions in the hospital. Follow-ups will be done 5 days a week until the desired goals are made or achieved, and continued with the program after 6 months to maintain the low heart failure 30-day readmissions. Data will be located at the electronic medical record audits. The project leader and nurse will be responsible for data collection, and data will be it will be reported to the ICU and medical surgical director. Okay, so that is this one. So we go to 18 ethical considerations. So autonomy. So these ones we already know them. I will just mention them. Autonomy, you see, the patients they need to have freedom to make decisions based on their needs, their healthy needs. Privacy, we have to protect them according to HIPAA laws. They have to have privacy, and their information need to be kept secure. And so, right to refuse care. They can choose to refuse care based on, they can say they want to go against medical records. So, if they decide to do that, they will be asked they have the liberty to leave. You give them the form to sign, and then they can leave. They can decide, I'm not signing, so you let them go, and they go. So that is their right to do that. So beneficency is provide care that benefits others, not malefficiency, not to harm people, because they come here to take care of them. So we are required to give them, to provide care that does not provide harm to anyone. Justice, treating all fairly. That's all I can say. We just need to treat everybody fairly. And that's all for that. I think that's all I've talked about that. So let's go to the next one, and let me move them all up because, okay, now. So 19. Okay, so to address this, let me lower this so you can see. Okay, pilot testing. To address heart failure, admission reduction, I use the Plan Do Study Act, a model. This model was used to strategize the pilot testing. And also, there are 3 questions which it has. And one is, what are we trying to accomplish? And for me, what I'm trying to accomplish is to reduce heart failure, third-day readmissions within 6 months by 5%. And then how will we know that a change is an improvement? We will know that the change is an improvement when what is proposed is achieved by comparing results from baseline data, which I showed you over there, to results of data collected during the project implementation on heart failure, third-day readmissions within the 6-month period. So the third question that it wants to answer is, what change can we make that will result in improvement? So the change we can make is something. Starting transitional care clinic within the hospital is something new that we do not have. I did really talk to the navigator, I had an interview with her, and we really discussed a lot of information concerning what she does. She told me it's a new thing that they are trying to see whether the calling and doing that will be able to prevent. But one limitation that she felt she had was she wished she was a clinical person. She would assess them because they ask questions that she cannot answer. And so she felt limited in that way. And that would be a very useful person already who is calling people to be beneficial, to be part of this clinic so that she can continue doing what she does. And then since the nurses are there, the nurses can be able now to do the assessment and respond to clinical questions. So I thought that was a nice thing. But at least we are doing fine. Just to have her to be following the patients, that is good enough. But we need to do more because of the barriers that she feels like she has. And yes.
I'm sorry, I actually need to ask. When you met with Rosa, and she said that she's not clinical, so when they ask questions, did she say, does she refer them to someone? What does she do if they have a question that she can't answer?
Okay, so what she okay, so when we talked about the clinic, and she said that there's a clinic out there where people are referred. So normally she calls the nurse. There's a nurse in that clinic whom she calls and tells, and talks with her to go and sends them there too, to go to that clinic so they can be seen there.
Okay.
Yeah, so that is how she takes care of that. But she wished she knew she was clinical. So, okay, so I think there's more here. So at least, so task 1, we are talking about the tasks above there. So task 1 is team training. Now the project leader will organize an in-class training by February 2024 at North Texas Medical Center to train and discuss AF third-day readmission prevention strategies. And the goal is to have at least 80% of the participants committing themselves to be part of the project throughout. So if they are committed, then we got this done because people will be there. So the other one is patient education. So a collaborative team of project members will be involved in patient patient education on heart failure frequency recognition and prevention. For example, patients who are admitted with heart failure will be seen by the case manager RN who will give them information on heart failure in their books. Nurses are to read the materials in details and explain to the patients what they entail. So the patients must be given opportunity to ask questions for clearer understanding. This is a good time to discuss and address patients' concerns and in a private setting. So the other one is number 3, client-patient calls. The nurse will make calls to the patients to discuss the transition care clinic and its benefits to them and make an appointment for a visit in the clinic. So appointment will be within 70 days after discharge, and hopefully all patients will come to the clinic for follow-up. So that is what we hope, so that can be taken care of. Number 4 is about provider referrals, and the healthcare provider at the transition care clinic and the nurse will assess and address patient needs as they collaborate with other interprofessional team members. Referrals will be made, if necessary, to primary health care providers, home health, by them, it should be by them. They are the ones to send it. Oh yeah. Referrals will be made if necessary. Yeah, if necessary. I said if necessary to them, to the primary healthcare providers, because some already have healthcare providers. They don't need referral for that one. All you do is communicate with them to hand them over to them so that they continue with the care. Those that do not have, then they need to be helped to get that referral, to be connected with the community, so that when something happens, they know where to go, and so that can be, and they can be calling, and everything will be done with them, for them there. So that is how. So the pharmacist will ensure that patients receive and understand heart failure medication management to promote compliance. Physical therapists, occupational therapists will work with the patients to strengthen their physical bodies, while dietitians educate them on diet modifications. So then the last one is data record. So patients identification, we say that nurses together with assistant personnel will collect data, record it in their personal records. So everyone on the team will be required to maintain patient confidentiality by signing off their computers. Once the computer is not in use, they need to close it and if someone finds it open, they need to close it, because we need to protect patients' information. So nurses and assistant personnel will be responsible for handling clients' information once they arrive in the clinic routinely. And then the last one is medical compliance. Nurse and pharmacist will educate patients on medication compliance and assist them in getting the medication if they cannot afford, by collaborating with the healthcare providers for free samples medication. Patients will need to know the benefits and side effects of medication and what to report to their providers. That way they can take control of their own lives when it comes to medication. So, okay, now we will go to pilot testing. It's just continued. And we are saying to pilot test the heart failure admission prevention project, a cohort sample of 5 patients with heart failure will be selected randomly and informed about the project participation requirements. So the 5 patients will be given a consent form. I think we talked about that to fill, and once they agree, then they will be put in the program, and they will continue for 6 months with the program activities, and hopefully they will not be readmitted in the hospital within that 6 period. Okay, so I brought this one here, the rank chart here. This is the first one in the head, and I want this one to be like what we use to measure our going, to know, okay, this is how we work. How did we do this year? So within the 6 months, we will be able to compare this and the data that we collect during that time. next one is talking about issues identified. So this is like things which can cause the project not to continue, and lack of support from stakeholders. You know, if they are not, I'm saying that stakeholders are people who have interest in the program, and if they are not, for them to support, you have to sell it to them 100% for them to be able to support and to see the need of even the existence of the program. So that is what that is all about there. So if you lack that, then nothing can take off the ground. So lack of enthusiasm among members. So if people they don't have enthusiasm, they are not interested in the program, it cannot continue. Patient non-compliance with the project activities. So the same too. So if they are not compliant, then they can't be helped because they will still keep coming to the hospital. And then lack of project team commitment. So when the ones that have already signed to be in the team, if they are not committed, then there is nothing that can continue because you need to work with him. They need to do their job for the project to move forward, you know, and also the patients to be helped. So lack of project team members commitment, and then lack of funds to run the transition care clinic. Sometimes, as I said here, I mentioned about things that we need to have. We will need to have oximeter machines. We need to have blood pressure things. We need to have like a room where we can set tables for assessment, for doctors and everything. Just set it like a clinic as it's supposed to be. For us to do that, we will need some little money to get started. So we need support for people to be able to do that. Lack of personnel. If there are no people who can do the job, then there is nothing that can be done. So lack of personnel can cause your project not to continue. So that is what that is all about. Okay, now here it's just the timeline this is the timeline for the project, and so that's what I'm saying. You see the development of the project. So within these days, then the first time, this will be the time the project team members, stakeholders and other supporting elements will be assembled. For example, rooms in which to carry out examinations, then the other one is develop teaching tools, and this will include handouts and heart failure 30-day prevention strategies. I will do research on the University of Arkansas, and also develop satisfaction survey. You know, we have that too. I saw it on the internet. You are doing so well on that one. Only some things which needs a little tweaking, but otherwise you are doing very well on that one. So congratulations for that. Then pilot testing. I'm saying that the heart failure 30-day reanimation patient will receive literature developed by project leadership concerning program goals and expectations. Some of the requirements will be for patients to attend the clinic within 70 days following discharge before they can visit their primary care providers. And what that is done is because you want to maintain the clinic and you want to be in control, and because your purpose is you are doing something and you are trying to look for something, you want to protect these patients. So if they go first to their primary care provider, then you cannot give them information because they have not come to you first. So you have nothing to give them to that. So even if they call, you say, I haven't seen the patient, so I can't give you any information. I have nothing. Let the person come here. Let me see the person, and then they can come see you. Then we can release their medical records. That is how that one is done, and I thought that was really cool. Okay, so I think that's it. And developing satisfaction, I've said that pilot process, data analysis and revision. So, okay, let's see whether there's anything there. I think that's it. That's it. Okay, so we're gonna go to the next one, which is, I'm almost done. Key findings, the results and staff responsibility, patient surveys and all of that. So, evidence-based research. Results, so I'm saying 5 evidence-based articles from the University of Arkansas Library associated with heart failure 30-day reanimation were examined. They outlined strategies that have been utilized to address heart failure third-day readmission in hospitals. This pilot testing project intends to implement a transitional care clinic with the goal to reduce heart failure third-day readmissions by 5% within 6 months in this place, North Texas Medical Center. This will include strategies such as phone calling reminders for appointments, referrals to primary care providers and other healthcare services, treatment within the clinic, and then PT and audit services. The 7-day follow-up from discharge is a critical moment for heart failure patients because literature shows that the heart failure patients are readmitted within 2 weeks. And so the 7-day is critical before they can come back to us, So these evidence-based strategies have shown to work as noted in the literature, and that is the reason it is believed that they can work in our facility as well. Because they have worked in other places, so why not use them strengths and limitations? So strength, we have patient benefit, low cost, easy to maintain, reduce facility oversight risks, and limitations we see is nursing compliance, medical support, patient or family refusal to participate, lack of transportation, and so I'm saying here that the patients will be the beneficiaries of this project because they will feel better and strengthen their lives, especially by using the physical therapies and being compliant with the medication and having follow-ups and providing follow-ups, then they will be able to feel better. So they benefit that way, low cost. Both the patient and the clinic will benefit from the project because project participants will not be readmitted for heart failure following their visit at the clinic. The North Texas Medical Center will save money and not have to pay for heart failure that readmission services. So there we gain. So patients will be assisted with the free medication samples to help take off financial burdens. And when I talked to the navigator, she told me that they have some funds to help people who cannot help themselves. So easy to maintain. The clinic will open for 5 days a week from 8 a.m. to 4 p.m. with 1 hour break from 12 to 1 p.m. And because the staff are trained to be responsible, the transitioning clinic should be easy to manage and maintain because of the training. So reduced facility oversight. Of course, oversight risks are reduced when healthcare professionals understand the health problems and take responsibility to address it as we are doing in this project. So that's a plus for us. How about limitations? So nurse compliance. Nurses are vital in addressing patient needs, and their compliance is crucial in this project because nurses play a bigger role in assessing patients' health problems and encouraging the patients to manage their own lives. And we become family with them, friends, but we become like mother. We help, they love us, and we maintain that relationship. Medical support. This program will be effective only when it receives full support from the hospital administration and stakeholders to allow for smooth running, team members, availability, and the provisions of services of the patients. So that can only work if they are willing to work with us, the administration. Okay, patients or family refusal. We already talked about that. The patients and the family are very important for this project to succeed. If they refuse to participate, there will be no project because they play a major role in that. So lack of transport to come to the clinic for follow-ups, appointments can be a problem. Therefore, these health issues will need to be addressed before and during the project implementation. That way will be good. That way that we can be okay with that. Okay, let's see. This is the next one.
You're gonna go to 26.
Oh,
Let's do the last
is the
one.
next one? Okay, thank you so much for your, okay, usefulness and sustainability. Usefulness, safe, efficient, cost-effective, and timely. Sustainability is self-support, ease of use, improve, and spread. So what about safety? The project makes sure that harm to patient is avoided from the care that it is intended to bring. So they come for safety, so we need to provide the care they need and not harm them. Efficient. The project will avoid wasteful use of equipment, ideas, energy, and supplies. Okay, and then cost-effective services provided will be based on scientific knowledge to benefit the beneficiaries, as we have seen before. So we know what to prevent, we know how the payment is done and calculated, so we need to provide quality care so that we can get what we need. And when we get the money, guess what? The patient benefits also. Timely, short ways, this is just shorten the ways and unnecessary delays for both service providers and the recipients. Patient-centered care, so must be respectful and targeted at patient preference and values, which should guide all clinical decisions. Okay, sustainability, what I'm saying is that staff support will be vital to sustain the project, and there will be mutual understanding and respectful communication among team members. Ease of use, project should run smoothly without hindrances or limitations. Improve safety, improve and spread. The project goals are to improve quality of life among patients diagnosed with heart failure. Once implemented and deemed effective, then project outcome will be spread through the internet, conferences, through the word of mouth, and meetings. You see, and meetings, people can meet and just discuss about the good things that we are doing, because it's a good new thing. So implementation for practice. Okay, so expand to other units in the system. If it works for us, for this clinic, then others will know what they can do to help to improve their services also, so they can also benefit. Improve care for more patients also, because like now, we are now dealing with heart failure. So what is the next one? So we can do that. So now I'm saying expansion of this project to other units is in the system will be done through 8:30 a.m. managerial meetings that occurs daily at North Texas Medical Center. This is a great opportunity because all directors of other units attended the meeting. And so you don't need to, that is really an easy way of spreading to the unit, because every department now comes to the meeting and they are able to hear and to know what to do. So improved care for more patients will be achieved through well-informed professional team members. For example, nurses provide patient-centered care on a daily basis, and hence will be able to educate and train patients to manage their own lives or health appropriately. So the last one is to reduce risk. The program's effectiveness will provide clients with the strength to be able to manage their own life activities of daily living. They can work because they have the PT and OT to help them with the movement and to strengthen their bodies. So that will increase their ability to exercise and to live longer, to get strong. Once the aim goal is met and the project is implemented, it becomes an adaptable tool to be duplicated in the hospital. And I think that is the end of my presentation, and this is where I got the references, where I got the information from. So, any question?
So you did a great job.
Yes, you did a great job. It's a great project.
Thank you. Now, I leave it to you to spread it. If you want me to come start the clinic, I'm available. We can get started. So thank you so much for listening. And